tumors and a lot more interesting as things have scientifically become a lot more, a lot has changed in the past handful of years with new studies. So this is one of my favorite topics. Okay, so again, we said medulloblastoma is about 20% of pediatric brain tumors. It's most often around kindergarten age, and we usually see it below age 10. 1 in 5 are young, less than 2 years of age. Leptomeningeal disease is about 1 in 3 patients, maybe a little less now. And there actually can have spread outside of the neuroaxis. This is like the only brain tumor that has the propensity to do this, and it occurs very rarely, like 1 or 2%. I've never personally seen it, but it has been reported and is part of the staging system. Okay, so medulloblastoma, these patients have presenting signs that are based on really the mass effect in general. Okay, so they have headache, emesis, papilledema, and lethargy due to high intracranial pressure. They can have ataxia based on the location next to the cerebellum, cranial nerve deficits based on the pressure on the brainstem, and then other motor signs based on its location next to the medulla. Okay, so medulloblastoma is one of our small round blue cell tumors. It can have glial differentiation or mesenchymal differentiation. Okay, there's multiple different histopathologic variants. Okay, so one of them is called desmoplastic medulloblastoma, and that's in 10 to 20% of them. Okay, and that's associated with the sonic hedgehog mutation. Okay, and this is important. This H&E scan here shows the nodular desmoplastic subtype, and nodular and desmoplastic sometimes are included as one term combined, but you can see here the nodular areas, okay, of the medulloblastoma. Then we have what's called the classic medulloblastoma, and then we have large cell anaplastic, which is also combined into one subtype by histology. Okay. Desmoplastic, or the nodular desmoplastic tumors, these are a special subtype of medulloblastomas, and they have overall good prognoses. And this is actually one of the studies from now, a while ago, from 2005, that showed young children with desmoplastic medulloblastoma and classic medulloblastoma treated with only chemotherapy after surgery. So these patients are actually curable with very high dose chemotherapy and do not need radiation. At least it's been shown in one study that they can have good outcomes. And this is for young children. Okay. Radiographically, medulloblastoma, this is a midline tumor. Okay, it occurs here in the posterior fossa. It's often solid tumor with enhancement throughout the area. Okay, on CT scan, it can be a very dense mass. Okay, this is 5 different pictures showing different types of posterior fossa masses. Okay, here's a hemangioblastoma, and this shows up over here in the cerebellum, associated with von Hippel-Lindau. Okay, your ependymoma is right here, and this is a 4th ventricular tumor, and the quintessential sign here is that it extends down into the spinal canal through the foramen magnum. Medulloblastomas in general will never do this. So if it goes down into the spinal canal, that's an ependymoma until proven otherwise. Medulloblastoma here confined in the 4th ventricular area. Pilocytic astrocytomas are often large cerebellar masses, and they can often have a cystic portion associated with it. Okay, and then here's another example of ependymoma sticking down here inferiorly. Okay, it doesn't quite get as far as the other picture does, but that's also an ependymoma. Okay, one of the key things that they like to ask you on questions, when we're looking at the actual scan on CT, both of them are hyperdense, they're highly cellular masses, but medulloblastoma tends not to have any calcifications, and ependymoma does. Okay, so the staging system for medulloblastoma, the T staging system doesn't really get utilized anymore. It's based on size of 3 centimeters or more, and then whether or not it has extension into the brainstem at the time of surgery, or if it goes all the way up past the aqueduct of Sylvius or down past the foramen magnum, okay, like an ependymoma would. And that's not very common. Okay, but we don't really use the T stage because it's not necessarily very prognostic anymore. is the M stage that really has the most effect in terms of prognosis and treatment. Okay, so this is the only staging system that I know of that has 5 different M stages. Has M0, which is basically no metastases. M1 is CSF only. Okay, I'm going to skip M2. M3 is anywhere down the spinal canal with gross tumor, so not just cytology, but gross tumor in the spine is M3. And then M4 is anywhere outside of the brain and spine. So it can be in the bone marrow. Okay, M2, this is a long explanation for basically just saying that it's in the brain outside of the fourth ventricle. Okay, so it could be like a cerebellar metastasis, like a separate spot, or something in the supratentorial region. Okay. So the risk stratification for medulloblastoma, in general, what we've been using, this is the generalization for the past decade or so, is that we have high risk and standard risk patients, and anybody that meets any of the high risk criteria would be included in high risk. So if they have metastatic involvement, so M1, 2, or 3 disease, if they have more than 1.5 centimeters squared of residual tumor, so that's supposed to be squared, not cubed, and that's because back in the day we just did this based on X-ray. So you would take an X-ray and look at the mass and measure out the cross-sectional area of the film. So that's really kind of out of play. In general, these tumors are well resected if you go to any institution that has good experience doing this, and they often get gross total resections of the primary site. Anaplastic histology was moved into the high-risk protocols in the COG a handful of years ago after finding out that anaplasia was a significantly worse prognosticator, even if they had M0 disease or gross resection. So they've moved that into high risk, and that's how they include it in their studies. And that's not all of the different medulloblastoma studies, but in general, you can think of anaplasia or diffuse anaplasia as being high risk. Okay, less than 3 years of age, we often also call it high risk, but they get treated completely differently than people who are over 3 years, and it's really its own category. But you can consider it high risk because they also tend to have worse prognosis. Okay, but that's really kind of falling by the wayside, and all the new studies are really looking at the molecular classification. And so this is one of the earliest areas where we've really adapted molecular genetics into our trials throughout both pediatric and adult radiation oncology, or oncology in general. Okay, so when we look at the molecular subtyping, they break it down into these 4 molecular subtypes: Wnt, WNT pathway, the sonic hedgehog pathway, and then the 2 others. And they just call them group 3 and group 4, and these 2 are a little bit harder to distinguish from each other. You can see how much overlap there is here in these genes at the bottom. Okay, but group 1 and 2 are really distinct entities, and they have, in general, better prognoses, with Wnt having the best. Okay, and you can see here, this one picture sums up the majority of the differences between the demographics, the clinical features, genetics, and what genes. Okay, so you can see which particular chromosomes and genes are amplified or mutated. Okay, so for group 3, these are MYC amplified. Group 4 are MYC-N or CDK6 amplified. Okay, but MYC amplification is very common and very high in these group 3 patients, and that it's associated with a poor prognosis, and they're often metastatic. Okay, the sonic hedgehogs we talked about are associated with desmoplastic nodular subtype. Okay, they're less common to have metastatic disease, and they're associated with this patch1 mutation, which is also associated with Gorlin syndrome. The Wnt pathway, these are very rarely metastatic. They have very good prognosis. They have the best prognosis of all of them. And even in the setting of metastatic involvement, they still have very good outcomes. So we're finding that these molecular subtypes are actually driving the outcomes a lot more than just the generic staging and the histology. So here's one analysis that they went back and looked at pathology from previous studies. and then categorize them based on what subgroup they were. And subgroup stratification, the Wnt patients, which was only 15 patients in this cohort of around 180 patients, they all survived. Okay? The sonic hedgehogs are here in red, and in general they have a little bit better, although it's not as well shown out here at farther periods out. The group 3s with the MYC amplification tend to have poor prognosis. Okay, here's the variability of the demographics in terms of age. Okay, so the sonic hedgehog pathway tumors are more common in the very young patients. They're less common in the average age patients over here. And then they're more common in the older age patients where it's not as common. Okay, and that's inversely related to the Wnt pathway tumors, where they're very rare in the young kids and in the older patients, the older teenagers. Okay, this is basically the proportion of metastatic versus non-metastatic disease between the 4 different subgroups here. And you can see here in group C patients, the MYC amplified patients, about 47% of them are metastatic. So they have a much higher propensity to metastasize, as opposed to the sonic hedgehog and Wnt patients, where it's less than 20%. Okay, and then this is another analysis, and this is breaking it down by the different subgroups and also by age. Okay, so you can see the differences here. In group 3 patients, and here in the bottom it's by metastases. M0 is a lot better than the metastatic patients. Group 3 with metastatic disease is very poor prognosis. Sonic hedgehog patients, if they have metastatic disease, also has very poor prognosis. Those that have M0 disease in general have good prognosis. When you look at sonic hedgehog based on age, the adults do better than the kids. You look at group 4 patients, and the infants here fare very poorly. In the Wnt patients, children with Wnt subtype had 100% survival, and the only patients who died were adults. Okay, all that being said, so if you have a patient coming in and you believe they have medulloblastoma, what's the associated workup? Okay, so you have to get an MRI before and after the surgery. The post-op MRI should be done within 48 hours to determine the extent of resection. Ideally, if you have an intraoperative MRI, that's better because they can get that scan immediately and they don't have to potentially go back to get more. MRI spine, you can do that at staging if you already are able to get that study done, but you can do that afterward. Post-operative MRI, if you do that spine MRI more than 10 days, it can be false positive up to 10 days after surgery, so you have to wait if you're going to do that MRI of the spine post-operative. Okay, CSF has to be done to, basically to make sure you get your M staging for M1 disease. Okay, regular labs. Okay, so radiation therapy. We have a number of trials. I think I tweened it down this year to make it a little simpler. But one of the original trials was this POG study back in 1990, craniospinal irradiation to 36 gray. So we consider that standard dose radiation for craniospinal RT. The whole posterior fossa got 54 gray, and residual tumor got 59 gray, and the 5-year overall survival is 80%. So we had actually very good cures of medulloblastoma dating back now almost 30 years. Okay. Now, subsequent to that study, we looked at doing what we call reduced dose radiation. Okay, so in this study, in the late 80s, it required patients have M0 disease with less than the 1.5 centimeters to be squared of residual, and they were randomized to 2 different doses of craniospinal radiation, 36 gray or 24 gray. The posterior fossa always got the standard 54 gray. And what we found out that the survival is lower by 10%, and the event-free survival was down by 14%. So using dose-reduced radiation therapy was not an effective treatment in comparison. But of course, there was rationale to decrease the dose because radiation, 36 gray craniospinal, is associated with a lot of toxicity, especially in young kids, who these patients often are. So, we have the original trial, which was RTL on 36 gray. Dose reducing was not effective. So then the subsequent trial looked at adding chemotherapy. Okay, so these patients had M0 disease. They had chemotherapy with radiation with weekly vincristine, which is the standard on the current COG trials. And then they had chemotherapy after radiation with CCNU, CDTP, vincristine, and they did that for 8 cycles. And then our event-free survival is back up into the 80% range over 5 years, and survival was up over 80% over 5 years, or 79% at 5 years, 86% here at 3 years. So we basically got back to where we were on the first study, but this is using the reduced dose of craniospinal radiation, but they all got chemo. So we never actually had a randomized trial of 23 versus 36 with chemotherapy. We just kind of switched over. Okay, so these are the chemoradiation trials. There's a number of them here with different doses of CSI. And here are your survival rates. Dr. Goldwine, and he did this back when he was at Penn. This is the first study that looked at dose reduced to 18 gray and had a 70% event-free survival with distant relapse in 2/3 of the patients who recurred. Okay, so in general, 5-year event-free survivals can get up to here in the 85% range using full dose treatment. Okay, so this Packer study, which is already 13 years ago, A9961, this is a COG trial. So I think this is the first COG trial here that we actually have. And that was 2340 CSI, 5580 to the posterior fossa with these 3 chemo drugs versus these 3 chemo drugs. So this was a chemo study. There was no difference in the different chemos, but we had 5-year overall survival, 86% in these average risk patients, and the 5-year event-free survival, 81%. So in keeping with the good 80% plus numbers, and this is basically where we get our standard doses that we've been using since then. Okay, now St. Jude has also had their own multi-institutional trials. SJMB 96 was done around the same time. That used shorter courses of chemotherapy, only 4 months instead of upwards of a year. Okay, but they used autologous stem cell transplant, so they supplemented their the duration of chemo with more intense chemotherapy requiring auto transplant. And then high-risk patients also had topotecan. And here, this included both average and high-risk patients. So we look at 5 years, and we're at over 80% for 5 years, and then around 70% here in this high-risk cohort. Okay, now this is more recent data, still not really published yet, but this information should be disseminated throughout radiation oncology community because our last COG trial had a randomized trial for 2 different things. Okay, so in this slide right here, patients were randomized to involved field radiation versus posterior fossa radiation. That was one of the randomizations of the recent COG trial. Okay, and these were average risk patients who anaplastic histology was not allowed on this study. Okay, so they had gross total resection or good resection, M0 disease, not anaplastic, randomized between involved field, which is basically just the tumor bed plus a margin, versus the entire posterior fossa, which is what had been going on previous studies. And as you see here, the lines are on top of each other. Okay, for both, this is for survival based on 82 versus 81% event-free survival, and then here's overall survival on this arm, okay? And it's 84 and 85%. So it made no difference if you did involved field or posterior fossa in these average risk patients. So based on this, it is okay to do tumor bed only radiation, okay? There are a few other studies that looked at this. This is one of the precursors. 32 patients with radiation only to the tumor bed, 27 patients or standard risk, and 5 were high risk. Most of them had chemoradiation. These are the different doses they gave, 23 or 36 gray. And they basically looked at the different doses here. You can see how much difference there is to the cochlea, temporal lobes, parotid glands, pituitary, and hypothalamus when you're doing entire posterior fossa boost versus involved field. Okay, and this was their data. Freedom from failure outside of the posterior fossa, still here 80% long term. Okay, so we went from older techniques with 3D conformal to using IMRT, which also helps decrease the amount of radiation to organs at risk. Okay, these are old pictures here, but you can see here, for example, the cochlea being better spared utilizing IMRT. And then the pituitaries more anteriorly and also better spared with IMRT. Okay, now this is just a couple pictures doing whole posterior fossa radiation. Okay, so you contour the tentorium. Notice when you're doing whole posterior fossa, you're including the entire brainstem as well as the entire tumor bed. Okay, here's a lateral projection of that. This is utilizing protons, and you can see the fall off here from the posterior fossa is pretty fast. Okay, this is involved field radiation with protons, and you can see the tighter isodose lines in comparison to the whole posterior fossa target on the previous slide. You can see here how the temporal lobes, which are contoured, are avoided better using involved field and with protons. Okay, and everybody's seen a slide similar to this. This is craniospinal radiation utilizing protons. This is craniospinal radiation using photons. You can see right here where the match line is, and there's a little bit of an overlap over here. And then if you subtract the proton from the photon, you end up with this is the extra radiation that's delivered utilizing photons. In the whole brain field, of course, there's no difference. Okay, so here's a composite plan with protons. And here's whole posterior fossa, and here's just the whole CSI. Here it is in an adult, where we can spare, or an older teenager who's past puberty, we can spare a large portion of the vertebral bodies, which helps spare their bone marrow. In younger kids, we treat the whole spine, including the entire vertebral bodies, to help minimize any growth abnormality. Okay, so here's that 0331 trial. Young kids, ages 3 to 7, were randomized between 18 gray to 23.4 gray of CSI. They both got at least 23.4 to the whole posterior fossa. Then they received a boost, and there's a second randomization, if they were young, to either posterior fossa boost or involved field boost. If they were 8 years or older, they all got 23 gray, 23.4 of the CSI, and they were randomized to posterior fossa or involved field. In this study, they used the 1.5 centimeter margin for GTV. So we have 2 randomizations on the young kids and 1 randomization on the older kids. Okay, they all got vincristine weekly during radiation, and then they got chemotherapy subsequently for about 1 year, week 55. Okay, and so here is the other randomization. For the kids aged 3 to 7, looking at low dose craniospinal versus standard dose craniospinal. So now we're calling standard dose 23.4, even though this used to be called the reduced dose in comparison to 36. So it's just the nomenclature. But this is 18 gray versus 23 gray, event-free survival and overall survival. And we can see that these two curves are substantially different once we get out about 2 years. Okay, and this p-value here was 0.06 and 0.08. Based on this analysis, the lower dose was not felt to be not inferior, because this was a one-way non-inferiority comparison to the standard dose. So because it's not inferior, you can't dose reduce to 18 gray unless they're on a protocol that would indicate as much. Okay. Now, comparing again the tumor bed to whole posterior fossa, copy that here, and you can see there's no difference on that second randomization. Okay. The cumulative incidence of isolated local failure by radiation group, whether it was involved field or posterior fossa, the rates of failure, again, are generally low. In 5 years, it was a 2% rate of isolated local failure versus 3.7%. Based on the 2 different tumor boost volumes. Okay, and none of the involved field radiation posterior fossa failures were outside of the boost volume. Okay, so very little, still very low rates of failure, and it's felt that involved field radiation is considered okay here. Okay, and here's a cumulative incidence of isolated distant failure by CSI group. Okay, and here it was 13% versus 8%. Okay, so from this study, the involved field boost is not, an involved field boost is not inferior to whole posterior fossa irradiation, so it's okay. But reducing the radiation to 18 gray is worse than 2340 for these young kids. Now, for high-risk patients, there was a relatively recent phase 2 trial, which is what we're currently using on the current COG protocol. This study had 161 patients, so this is a sizable study of patients with metastatic disease, had weekly chemo, and they also added daily carboplatin during radiation. Okay, so this is a lot more concurrent chemotherapy. They had standard dose 36 gray CSI for high-risk patients, and the entire posterior fossa was treated at 55.8. Then they had further chemotherapy subsequent. Here's stratification by M1, M2, and M3 disease. Okay, and then here's a substratification based on anaplasia with progression-free survival in yellow and blue, and then an overall survival in gray and red. Okay, so the patients who have anaplasia, you can see the yellow and blue, there's a substantial difference in progression-free survival if they have anaplasia. And the same goes for the overall survival. So on the 0332 protocol, which is unbelievably now like 15 years ago that was started, they did another 2x2 randomization. They randomized to carbo during radiation or no carbo. And then they also looked at isotretinoin added on with the regular chemotherapy. And this also included the M0 patients with diffuse anaplasia because they were not allowed on the standard risk protocol. All of these patients had a whole posterior fossa boost because that was the standard of care at that time. And that study is not yet completed, so we're still waiting for that. But in general, your standard risk outcomes are going to be around the 80 to 85% range, and then for high-risk patients, it's about 10-15% lower in general. Okay, so standard of care. We didn't talk much about the young kids, but for the young kids, we're going to do chemotherapy first. Okay, anybody older than 3, they're going to be treated as a standard or a high-risk patient. For standard risk patients, we do 23.4 CSI, and we boost 54 or 5580 to the tumor bed plus a margin. Okay, and that margin is 1 to 2 centimeters standardly. New protocols are doing even smaller margins, but that's a good margin to use, 1 to 2. It's a lot smaller than whole posterior fossa. Chemotherapy is done adjuvantly, plus or minus concurrent. So as an aside, the St. Jude trials don't do chemo during radiation. They only do it adjuvantly. The COG trials do it both. Okay, so but we agree on adjuvant, and the concurrent is one or the other. For high-risk patients, they're getting 36 gray craniospinal, so the full dose of craniospinal. The boost is 54 to 5580. And then again, it can be to your tumor bed plus a margin, or it can be to the whole posterior fossa, since that is what was done on the most recent trial. People debate about which of these two because this was not studied in a randomized fashion. But off protocol, this has been what I've always done, tumor bed plus a margin for a high-risk disease. Okay, and they always get chemo adjuvantly plus or minus concurrent. Okay, so the late effects of craniospinal irradiation, neurocognitive effect, attention deficit, short-term memory change, visual motor skill change, hearing loss from radiation and cisplatin, endocrine deficit. So growth hormone is the most likely to be affected because growth hormone is affected at low doses of radiation, even like 18 gray to the pituitary. Hypothyroidism, gonadal endocrine deficit. Skeletal growth can be decreased both from the growth hormone deficiency, but also because we're irradiating the bone itself, which affects growth. And then the heart and lung, especially if you're using photons, vascular, and then second malignancies. So whether it be a cancer or be meningiomas, which are common long-terms out from CSI, certainly these are long-term risks. Okay, so this is a study that shows the mean changes in IQ based on age and risk group. Okay, so in the top left box, we have the older kids, older than age 9 with standard risk disease. IQ looks to be relatively flat. Okay, older kids with higher risk disease, when you're going to 36 gray, the IQ decreases a little faster. Okay. For younger kids, standard risk disease, it goes a little bit faster than in box B. And then in D, it's the young kids with high-risk disease getting 36. So they have the most substantial decrement. So this is in the like upper 90s starting out, and they end up over here 6 years out under 80. So that's a substantial decline. Okay. Now the predicted mean changes in reading are seen here. So we have the same 4 slopes, relatively flat, and then steeper over here with the higher doses. Okay, so late effects, again, this is basically showing different scores from the previous, and in general, the same things show up. So older kids with lower doses of radiation have a lot more maintenance of their neurocognitive function. Okay, so this is a chart of different deficits that people can have based on dose. So growth hormone can be affected as low as 18 gray, puberty, 20 gray. Thyroid hormone can actually be affected at these lower doses. The other pituitary hypothalamic functions tend to only be affected at higher doses, at 40 gray or so or higher. So these are much less common to be affected. Okay, so how we do craniospinal radiation. This is going to be a little bit more for the oral boards, but ultimately your goal in doing craniospinal radiation is to cover all of the subarachnoid space. So basically everywhere there's CSF, because that is the way that the disease spreads. So there are a lot of ways to do one. Here's a simple way to do it, and this is what most often people use and memorize for the oral boards because it's easy to explain. Is that a patient is supine? A patient is prone, and most people I don't think use prone anymore, but a patient is prone. Use 2 opposed lateral fields, okay, for the brain, right here. Okay, and then you use 2 for the spine, or 1 if this person is short enough. Okay, so you have 2 spine fields and then the lateral brain fields. Okay, you have a match point over here, and you have to be careful not to have it hot on the spinal cord, so you match it like anterior to the cord. Okay, and then the collimators have to be rotated so that you're flush with this field right here. Okay, so you do an aquaplast mask. You can have the neck slightly extended so that the photons don't exit through the mouth. Okay, you can use some sort of an immobilization device like a vac lock if you'd like to. Pulling the arms down can help to make sure that the shoulders are not in the way because the brain fields are going to go into the neck a little bit. Okay, you want to use lower energy beams to make sure that, you're getting full dose close to the surface of the meninges, because the spine can and the skull, those meninges are close to the surface. You don't want to underdose that area. Okay, so often people will say the cranial field will go inferiorly to around C5 or 6. Okay, anteriorly you have to include the entire cribriform plate. That's very important. Okay, the spinal fields, okay, are going to go up until the bottom of the cranial field. So example is C5 or 6. Okay, you want this to be as low as possible without the brain field having to go through the shoulders. That's why having the shoulders down can be helpful. Now, if you have 2 spine fields because the patient is too tall, you have to decide where the lower border of the upper field is. The easiest thing to do, if possible, is to make this upper border inferior to the L1, L2 area so that you're below the thecal sac, and so that your junction over here is actually not even on the spinal cord at all. Okay, so that's ideal if you can reach that far. Okay, then the inferior field will match with the superior spine field, and you're going to go all the way down to the bottom of the thecal sac with a little bit of a margin. So you should usually go to at least the S2, S3 junction. Okay, you always want to look at your MRI and find how far the thecal sac is. So I look on the T2, I look at the white thecal sac fluid, and you're going to see where it ends right here. And then I'll add a little bit of a margin to make sure it's well covered. Okay. Here's the picture of the gap calculation. You have your upper spine field and your lower spine field, your 2 SSDs. You have how wide each of the fields are. This is a geometry, similar triangles calculation, and then you can look at your skin gap. The reason why people say prone is because the skin gap calculation, you can measure this on the table when you're at simulation. You can literally draw these lines and draw that gap and measure it out. And then when you go for treatment every day, they can line up the light fields to make sure that that skin gap is there. That's the primary rationale for utilizing prone when you're saying how to do this, because you can say, I can measure out my skin gap. On a supine treatment, you can't measure your own skin gap. Okay? So here's the spinal fields. You have L1 up here and L2 over here. Okay? And you want to make sure you're matching just anterior to the spinal cord if you're on the spinal cord. Okay? Laterally, old school technique with an X-ray, you're going to add 1 to 2 centimeters lateral to the pedicles. You just have to make sure you're covering the arachnoid space. I actually contour this on CT scan and make sure the fields are wide enough. But 2 centimeters on the pedicles is very wide. Okay. Now the cranial fields, because this line right here is on an angle, you have to rotate your collimator, okay, to make sure that you're parallel here. Some people put a little small gap to make sure you're not overlapping on the spinal cord here, because that would give you like 3.6 gray per fraction on the spinal cord, and that's dangerous. Okay. So your collimator angle is going to be based on this angle right here. So you just do a simple arctangent of this over SSD, gives you this angle, which will be the exact same angle as this rotation of the collimator. Okay. Now the couch. Some places will do a couch kick and some places will not do a couch kick. If you do a couch kick, you just have to know how to explain this. So if you're lying straight on and you have your cranial field diverges superiorly and inferiorly. So what happens is you're going to get this line crossing over your spine field. If the couch is rotated inward toward the gantry, which is on the left side of the screen, okay, now this spine field, the top of that spine field is also angled, and it can match the divergence of the cranial field. So that way you're getting this to be flush in this direction, and the collimator rotation is to make sure you're flush in the ant to post direction. Okay? So you're going to kick the couch here when the beam is coming from the patient's left side, and then when the beam is coming from the patient's right side, you kick the couch toward the right side, and that moves the spinal field in this direction. Okay? So and that's simply a very simple arctangent calculation, again, to calculate what that angle is. Some places don't do a couch kick. They just make a very small gap and then just let it mildly overlap. But it's very, very little. You're not really overlapping because you have the skin gap there. Okay. Where you put the central axis of the brain, okay, people do it differently. You can put it, because the brain field diverges, some people you have to accommodate for the radiation that goes through the contralateral eye. Okay, so you can put the central axis near the eye and just use a half beam block to prevent it from going into the other eye. Okay, and then here's just a one-by-one, step-by-step guide on how to do your cranial spinal radiation planning. Okay, and so I talked about you don't need to do a couch kick if you have a small gap. Okay. The last thing is, because we're matching up these lines, there can be some overdose or underdose. So we have to do what's called feathering throughout the course of treatment. And that feathering is to help move that line so that you're not there for the whole treatment. So you can feather it every 5 fractions and basically move up your fields, okay, or move them down. You can do either way, as long as you know what you're doing. Or you can do shifting every day during the course of the treatment with 3 different plans using your MLC leaves. And that's what I would prefer to do if I was using photons, because your MLC leaves can do the feathering for you, and then you just have one easy plan that goes from the beginning to the end. Okay, so here's an example. The first plan is like this. You have your 2 spine fields and your 1 brain field. Your second plan, you just move one of the leaves out of the way so that this field gets shorter. Okay, your upper field, you move both of these up, for example, 1 centimeter, and then your lower field, you move this up 1 centimeter. So basically, your junction just gets moved a centimeter here. Okay, and then the second plan, you just open up a second leaf on the brain field. Okay, and then you just open up these 2 fields by 1 leaf and this field by 1 leaf. So then that moves it up another centimeter. Okay, so you just plan all 3 of these at once, and then you have your plan for the whole treatment. Okay, this is the I'm talking about with the feathering at each day. So you have your upper spine and your lower spine. Okay, so the first fraction is like this with the lower spine closed. Then you open this one up and you close this one here. And now you still have a nice straight rectangle. Close this too and open this, straight rectangle. And then you can do it one more time, and that's not on here. So basically you have your three plans just using your leaves. Okay, good. So moving on.